Good afternoon and welcome to today's webinar. This is Ken DeSergio, Deputy Project Director for the National Quality Improvement Center for Collaborative Community Court Teams. Welcome to all of our quick sites. Hope you're well. Hope our colleagues throughout the country are doing well and dodging the winter weather, and as you prepare for the holiday season as well. Today's webinar will be on plans of safe care, state examples. In a few minutes I'll introduce Jill Gresham, our presenter today. A little bit of technical information. If you look at the screen, for those of you that are on Adobe Connect, up in the right-hand corner, if you're having any trouble with accessing via phone line, you can call 877-273-4202, and the access code is up there on the right-hand corner of the screen as well, 594-442-080. If you're not on Adobe Connect but can hear me on the phone and you're having any technical issues at all, you can call Michael Franzen at 1-866-493-2758, extension 8965. We're going to have the phones muted until the end of the presentation, the discussion presentation, and you can use the chat line. You see that in the lower left-hand corner of the viewing area, if you will. And then all of the files that Jill's going to be presenting today and discussing and viewing with you are in the lower right-hand corner, and you see it under Files 3, and those can be downloaded at any time during the webinar, so you have copies of that material as well. So with that, we'll proceed with today's webinar. A reminder, the National Quality Improvement Center for Collaborative Community Court Teams, or QIC, as we all come to refer to it, is a program of the Children's Bureau and the Administration on Children, Youth, and Families. The Center for Children and Family Futures is proud and pleased to be able to implement the National Quality Improvement Center on behalf of the Children's Bureau. I want to frame today's presentation in the context of the first two goals of the QIC, goals of the QIC program, and all of you out there are very familiar with these goals. But we're going to talk briefly about the first two goals: implementation around enhancing the capacity of collaborative community court teams to implement the CARA amendments to the Child Prevention and Treatment Act, or to CAPTA. And then the second goal, the capacity around around addressing the needs of infants, young children, and families and caregivers affected by substance use disorder. So think of the first goal to address the needs of infants and their families and caregivers identified at birth, right? So the notifications to child welfare, to child protective systems for infants identified at birth by healthcare providers, and the need for plans of safe care and the wraparound services for that population. Think of the second group as more broad, if you will, not just those infants identified at birth, but the needs of all the children in those families that are affected by substance use disorders. And it also gives us the opportunity to go more broadly than just a response to an affected infant at birth. And that would include developing plans of safe care and or linkages to prenatal health care providers. Some of the strategies and approaches that Jill will discuss today applies to both of these goals. And as we collectively proceed, and as you proceed in your collaborative court teams with initial implementation, we want to assist you with implementation strategies to address these two goals. In a few minutes, we'll see a slide where we've kind of looked at your semi-annual progress reports and summarized some of the work around plans of safe care. But planning to implement the strategies around the first two goals certainly includes outreach to prenatal and maternal health care providers. Again, infants identified as prenatally exposed and the response system, the need for services and plans of safe care for that population, as well as parent-child interventions to enhance parental capacity to care for their children and to care for infants that may be prenatally exposed. So how do we prepare those moms and those parents or caregivers to care for an infant that may have gone through, may be experiencing neonatal abstinence syndrome, or manifesting other behavioral effects as a result of their prenatal exposure. We will open this lines up later in the presentation for discussion. We hope that at that point in time that you take the opportunity to network and share some of your work, and we've got some prompt questions to do that. And then in the future, we'd like to conduct networking webinars. So as you hear today's presentation and some of the strategies, we'd like for you to be sharing some of your strategies in the coming months into next year about the work that you're doing. And we'd like to feature a number of your sites in the networking webinars over the course of the next year. And with that, it's my pleasure to introduce Jill Gresham. A number of you, you all heard Jill at the All Sites meeting, and she's been on site with several of you. And just a little bit of background on Jill. She serves as a senior program associate with the National Center on Substance Abuse and Child Welfare at the Center for Children and Family Futures. In this role, Jill serves as an advisor and technical consultant to states, counties, tribes, and regions across the country in issues related to substance abuse, child welfare in the courts, and providing and coordinating various levels of technical assistance. Jill primarily serves the in-depth technical assistance program and provides support to states working to address infants with prenatal exposure from pregnancy through infancy. And with that, I'll turn today's webinar over to Jill.
Thanks, Ken, and welcome everyone. You can see the agenda up on your screen right now, and as Ken mentioned, I've been working in the in-depth technical assistance program through the National Center. And today's webinar really is going to be an opportunity for me to provide all of you with a lot of what I've learned working with states in terms of some tips and tricks and ideas for how different states and jurisdictions have really gone about implementing the Plan of Safe Care. I think for every state there's a different solution, and I hope that this will be helpful for you to think through and see how some states have really thought outside the box in terms of addressing challenges related to the implementation of the Plan of Safe Care. So we're going to do a very, very brief overview of the CAPTA legislation. My guess is most of you are pretty familiar with that right now. And then we're really going to dig into all these different areas that you see up on the screen. What I did was to craft this webinar around the planning document that the National Center created, and the planning guide is really a step-by-step for states and communities to implement the plans of safe care. It really starts with state-level decisions and gets all the way down to front line. So we can't cover all of those different areas today, so I really sort of picked and chose different areas that were really more specific to implementation challenges. And I do have a variety of different files that we can pull up and examples. So if you're unable to download those, we can certainly get those out to you through your CL if there's something that you're needing. So with that, let's jump into to that very brief overview of CAPTA and CARA. If you can recall, CAPTA was first introduced back in 1974. It's a relatively large piece of legislation. When we talk about CAPTA with quick, what we're really talking about is a pretty brief passage that talks about and addresses infants who were born prenatally exposed to substances. And that passage appears in 2003 for the first time. In 2010, there's an amendment to it that adds fetal alcohol spectrum disorder. And then in 2016, as I'm sure many of you are aware, we see quite a few changes to the Act itself. So some of those larger changes, I think the big piece is they struck this word illegal. And so where prior to 2016, we were talking about infants who needed a plan of safe care, and those infants were born with and identified as being affected by illegal substance abuse. So they struck that word illegal because they were seeing an increase of infants exposed to prescribed substances, and so it was an effort to ensure that those infants also got a plan of safe care. The other big change was that there was a shift, so whereas previously the plan of safe care was really focused on the infant, now it was focused both on the infant and the caregiver and family. So that plan of safe care needed to be broadened to include substance use issues, mental health, et cetera, health issues of that mom or that primary caregiver. So again, sort of that wrap-up, that word illegal got struck from that definition of what an infant exposed to substances was. We also saw sort of an increase in data that needed to be reported by the states to the federal government. So states need to report the number of infants born if affected, the number of plans that were developed, and then the number of plans that had referrals for that infant and caregiver. Again, we saw the plans being expanded to address the needs of both the infant and the family caregiver. And then there was this fourth piece that said that there needed to be increased monitoring and oversight by state. So really looking at, are these plans of safe care happening? Are they effective in supporting families? So there's a very brief overview, a snapshot of those changes related to CAPTA and the plan of safe care in particular. Ashi is going to take us through a polling question.
So this is our first polling question, and it is really to get an idea of cross-systems knowledge within your community. The question is, to what extent do your team members and key partners have an understanding of CAPTA and the recent CARA amendments to CAPTA? The response options are not at all, very little, somewhat, to great extent, and not sure. So please mark your answers, and then we will come back in a couple minutes to discuss the results. Okay, looks like we have a sufficient response rate. Good thing is that no one said not at all. The majority, it looks like about 70% said somewhat. All right, back to you, Jill.
Thanks. So, all right, we're going to jump into the role of implementation teams. So again, this is pulled from that planning guide. You can see a little snapshot of that up in the corner. This is something, if you don't have, we're happy to send this out to you. So the guide goes into great detail around implementation teams, that they need to be cross-system and interdisciplinary, and make sure that we have all voices represented at the table. So I didn't want to spend a whole lot of time on this. My guess is this is something that you all are digging deep into in your respective communities and with your change leaders. I'm sure your change leaders are asking you who's missing from the table, and so I think you're digging into a lot of this. But what I have heard folks struggling with is how do we engage medical providers, which I think has been challenging for a lot of the sites that I've worked with. So I thought I would just share some of the areas where we've gained some traction in terms of engaging some medical folks. I think one of the first big areas of learning I had was around the hospital association. So I think just about probably every state has a hospital association, and these are folks who really do some advocacy work and support hospitals in their regions, and they're folks often who have a little bit of time as well. So there's someone who could really sit on a steering committee or maybe an oversight committee. They're people who can tell you who the best person is to target at a hospital based on what you need to get done. There are also people who can really give you some good feedback if you're wanting to maybe change like a drug panel or changing some sort of policy or protocol at a hospital. There are folks who could say to you, that's not going to really go over well, or you might consider this, or rewording it this way. So they've been really invaluable members. The other thing is that hospital associations often are at the state level, but I've also seen them regionally. So recently we started working in North Carolina, and they have in the western sort of rural, more mountainous area in North Carolina, there's a Western Region Hospital Association that supports some of those more rural hospitals. So if you haven't connected with your state or local hospital association, I think they're really valuable resources. I think county and state health departments, you probably have some engagement with the county health department. We're starting to see lots of states starting to track things like NAS rates, and they can have a lot of that valuable data. They often don't have direct oversight of hospitals, but they do often oversee a lot of regulations. So sometimes there could be some crossover there to understand, again, who's the best person to talk to, right, if you're wanting to start working with a hospital to change practice. Similar to the hospital associations, there's also state and local chapters of the AAP, the American Academy of Pediatrics, and also ACOG, which is the American College of Obstetrics and Gynecologists. We have had a notoriously difficult time engaging OBGYNs, and I've been told by more than one person that if you want to get sort of a group of OBs together in a room, really ACOG is the best way to do that. They usually have some sort of regular meeting or trainings that happen a couple times a year. They're great places to maybe send out a survey. We had one state that made, connected CEUs to filling out a survey about their screening practices. So just another way of engaging folks. Then also thinking through who you're targeting at the hospital. We've often worked with hospital chairs for some of the bigger questions. So again, thinking sort of like wanting to change a drug panel or wanting to outstation a child welfare worker. So we frequently have worked with chairs of pediatrics or OB chairs. Sometimes we've had chairs, neonatologist chairs as well. But when it really comes to sort of on the ground work, the person that's going to understand what information gets shared, who's getting called to child welfare, why and when and all of that. It's really going to be either the hospital social worker or the nurse supervisor. Both of those folks I've found have some flexibility in their time to be able to sit on things like monthly calls and to engage with like a steering committee, and their information again has just really been invaluable. Also, we've had some crossover with child fatality review commissions, and some of those folks also have connections to the hospitals and relationships with the hospitals and ways in. So next step is, once we have that implementation team, what are we doing in terms of developing the plan of safe care? So really thinking through what information needs to be included in the plan of safe care, what elements are they covering, who are they covering it for. Many of you may be in states where you've already been given some sort of template that is already kind of done for you. Some of you might have some flexibility to be able to change that template. What you see up on the screen is from the planning guide, and it was sort of our teams thinking through what really should or could be included in the plan of safe care. This really is not delved into in the federal statute, so this is just something that we thought, in good practice, could be included in that plan. But some key components to think through. I know you all have heard us talking about the opportunity to implement that plan of safe care during the prenatal period. If we know that infant's coming and we know that infant is going to be needing a plan of safe care, it sort of makes sense to get upstream and start that plan during pregnancy. Again, it would include the treatment needs for parents and for infants, and other sort of broader needs that are not necessarily just safety concerns. I think the big piece, too, is how do we involve systems outside of child welfare? So I've seen in lots of states, and this might be happening in your state, that child welfare really is taking ownership of all plans of safe care. And so my question is for them is, how then is that plan going to be shared? So if the plan is supposed to support collaboration to support that family, how does child welfare inform other system partners that that plan exists and that these are the goals for that family? Some states have child welfare hold that plan in sort of an assessment track, so they might not be opening a full case, but there's maybe an assessment track that lasts maybe 2 or 3 months, and then they're done and they're closing. So one of the things I'm encouraging them to do is to think through, how could I hand this plan off, right? And so they're thinking through maybe putting sort of a checkbox at the bottom saying, what, this family's wrapped up and they're done, or no, we're done with this family, but there are still some needs, so we're going to pass it off to this treatment provider to continue to oversee services. What is a plan of safe care? I think y'all are probably thinking through a lot of this as well. It's not a safety plan. It's not a treatment plan. It's not a hospital discharge plan. But again, it's sort of a culmination of all of those things. It goes beyond just mom or dad's treatment needs. It goes beyond the immediate safety needs. It goes beyond health needs. And really, it's a culmination of all of those things together. Ken, I think this is you.
Sure. So we took a look at your semi-annual progress reports that you submitted back the end of October, kind of just be able to get a quick overview as to the status of implementation of the CARE amendments to CAP, their plans of safe care within your states and then within the demonstration site. So we put this together and summarize it, as you can see. So 5 states of the 9 states with that represent the 15 demonstration sites. 5 states have issued guidance related to implementation of CARE amendments. And that's either guidance or it could be regulatory, if you will. A number of states have done legislation, have passed legislation, or in the process of passing legislation. 7 demonstration sites have reported they've begun to implement plans of safe care in some capacity within the jurisdiction that the courts are being implemented, your collaborative court teams. 2 demonstration sites reported that the court is involved in implementing and reviewing plans of safe care. I've been on several site visits and understand that often the plans of safe care are under the jurisdiction of a parallel dependency court and not necessarily under the jurisdiction of the specialty court. But we've had those discussions on site with several of you and your judges around asking about plans of safe care, asking about the status of plans of safe care, even though your court may not be directly responsible for an individual case plan or the plans of safe care. If a mom, if you have a participant in your court that's recently given birth or that's pregnant, just asking the participant, asking mom, asking child welfare worker, does this family have a plan of safe care? Does this infant have a plan of safe care? What's the status? And then bringing it back to the other parallel courts in those situations. 3 demonstration sites reported that they are using a standalone document for the plan of safe care in at least some cases. There are a number of jurisdictions where state guidance has incorporated plans of safe care into existing child welfare documents, if you will. So in a couple of states, incorporated into an individualized services plan, as the situation is in Alabama, or into a functional family assessment. But there are also several jurisdictions that are implementing a standalone document. We've spoken with several of you about considering a standalone plan of safe care during prenatal care, during pregnancy. So, and that would not conflict in any way with state guidance and incorporates it into child welfare processes, if you will, since in most jurisdictions, unless there's already an open case, child protective services would not be involved until birth. So the opportunity for potentially developing a separate plan of safe care during pregnancy, and as Jill indicated, could be used to inform what happens at birth, child welfare response to an infant who's born affected by prenatal substance exposure, and could also inform the development of a plan of safe care by child welfare for those jurisdictions that do incorporate it into existing CPS processes and documents. And then the common challenges that you report experiencing identified include a lack of clear guidance from the state level and limited educational plans of safe care in the community. There's different levels of rollout by states, and many states are in the process of doing training and implementation and rolling out plans of safe care. So it's really quite a variety of implementation statuses on the states with whom you're working and with whom we're working. To kind of get further clarification, again, this is a review from your semi-annual progress reports. We consulted with the CLs to give us feedback. And I've asked to change liaisons in the coming couple of months as they're engaging with you and as we come back on site with you to really talk about plan of safe care implementation. And to talk about where your jurisdiction is at with it, and to what extent your courts can be involved in reviewing those plans of safe care, or certainly in advocating that those plans of safe care be developed and implemented. Jill?
Some practice considerations for developing a plan of safe care. We have many, many different templates. They range from about 1 page to about 23 pages, so there's a lot of flexibility there. Don't feel like you have to reinvent the wheel. If you're playing with a new plan of safe care, reach out to us. We know parental involvement is key. We want to see that mom or dad or caregiver be involved in the development of a plan of safe care, so we have seen our sites always putting out like a signature page at the bottom of that plan of safe care so that the family members can all sign off. I think it's also good to think through how we can roll consent into that plan of safe care. So can we include a consent page as part of the plan of safe care? Some states have looked at maybe putting a checkbox, say, hey, we have this consent, and then maybe there's a copy of that consent along with it. So we know we're going to have to get consent to share that plan. It would be nice if all the plan participants knew that that the consent had been gained. And then Delaware actually did this and have been encouraging lots of other sites to do that, which is to identify all the plan of safe care participants on the clinical team. So you know who else is working with that family. Everybody's on sort of the same page, and their phone numbers and emails are all there. You can weave that consent into that piece as well. And then really thinking through how are we going to share that plan of safe care across participating agencies. I think this continues to be a challenge. There are some jurisdictions who have been able to use some of the medical record systems. I know lots of folks have been changing plans of safe care to be a fillable PDF, still lots of faxing happening, but we're certainly grappling with this one. I have a bunch of plans of safe care examples to show you, but I think we're going to highlight the Allegheny County, Maryland one. So in the file names on the right, this one's called Safe Care 2, or Safe Care Plan 2. I like the Allegheny plan because in Maryland, the state did not provide a template for a plan of safe care, and counties were able to implement their own plans, and Allegheny implemented the plan that you see, Allegheny County, the plan that you see in front of you. So it's pretty simple to fill out. It's a lot of different check boxes. They go into the child needs, the substance use needs for the parent, and then down to sort of resources and needs. They added a good signature page at the bottom after we talked, and so they're doing some work around the consent. So, I can tell you that in Allegheny, this was something that child welfare completed, and it stayed with child welfare. And so we've actually been having conversations with treatment providers. I had a call with them recently, said to treatment, hey, do you think it would be helpful to see this plan of safe care? Treatment said, yes, we really want to take a look at that. And so they're looking at how they can share that plan when child welfare develops. Treatment has also said, hey, we wouldn't mind developing this prenatally and then handing that off to you. And so they're looking at it. They need to change some things because it does talk a little bit about things like child placement and that kind of thing. So they're going to make a prenatal version of this, and then they're going to start doing that prenatally and sharing it with child welfare, and then sort of back and forth. So I'm not going to pull the Virginia plan up just because of time, but there is the Virginia plan, which is called the 11 Care Plan of Safe Care Template. You can take a look at that one. That's a good one-pager. It was initially based on Washington State's plan, and I know other states have also amended that for use in their jurisdiction. Just wait for the slides to come back up. So polling question, Ashe.
Thanks, Jill. So we'll go through this pretty quickly. This question is, our court team has a role in the development, implementation, and or monitoring of plans of safe care. And we just want you to respond yes or no to this question. Okay, that looks like a pretty decent response rate, and it looks like it's actually spread out across the board. But the majority do say that you are involved in implementation and monitoring of plans of safe care. To some degree, a little different than we expected, and we will have an opportunity at the end of this discussion to talk about strategies and ways in which you're implementing plans of safe care within your court teams. All right, thanks. Back to you, Jill.
So next piece after sort of developing that plan of safe care is a discussion about assessment. So we talk in the planning guide quite a bit about the need for a good, comprehensive, wide assessment of the needs of that family. I think one of the better, probably one of the few examples that I've seen comes out of Delaware, so we can pull this up. Delaware is the state that actually has the 23-page plan of safe care, and what they did at the end of the plan of safe care, so you can see really the first half is the plan of safe care itself, lots of family information, and then it goes into the family needs. but they wanted to include a strong assessment that went along with the plan of safe care. And so they developed this really nice family assessment. What they did was to tell providers, you don't have to use this assessment because we know providers are likely doing their own assessments. They're probably gathering most, if not all, of this information. But they said, hey, this is really what we think needs to be covered in a thorough assessment of the family. If you're covering all of this, great. If you're not, maybe there's some elements of this that you want to add to the assessment that you're doing so that when you do get to that plan of safe care, you're getting a good, strong, like well-rounded view of what's happening with the family. So polling question?
Yeah, we have another one. So we'll talk about this in a second. So the question is, there are state statutes in place that identify roles and responsibilities for development and implementation of plans of safe care. So again, if you can respond, that would be great. And we're just looking for a yes or a no. All right. So again, it looks like it's spread out, but barely the majority say no. There are no state statutes that identify roles and responsibilities. So again, we'll get into some of the nuances of this discussion at the end. Thanks.
Thanks. So the next piece, I think we have the plan of safe care. We have our implementation team. We've talked about the assessment process. I think the next big piece is who's actually getting the plan of safe care and then who's going to be overseeing it. I think this is probably where the majority of the work has happened in a lot of states that I've worked with. I also think this is where you see the widest variation of different responses. What works in one state, which works in one community, is not necessarily going to work somewhere else, but we just wanted to give you a big sort of spread of what's out there in terms of the thinking. So the first one comes to us from Vermont. Vermont is interesting because the hospital actually develops the plan of safe care. This is pretty unique for me. I can tell you in every other state that I've worked with, when I've talked to folks in the hospital, they have said that they were not interested and just too busy to implement the plan of safe care. Not the case in Vermont. It was something that they could take on. Oversight of the plan of safe care is split. So if there is an open child welfare case, then child welfare takes that plan of safe care and oversees it. If there is not a child welfare case, then the hospital actually sends the plan of safe care over to pediatricians who oversee it. So hospitals are making some decisions about whether to report to child welfare or not. If this is a case that they're not reporting to child welfare, again, they send it over to the pediatrician, and then they do some aggregate reporting to child welfare. So child welfare will have that data that they need to report up to the feds. Delaware has taken a multi-pronged approach for the plan of safe care. Child welfare has actually been outstationed at local hospitals, and they're developing plans of safe care for any infants that have any kind of risk concerns. They have a contracted provider who actually comes in and works with low-risk cases. So at this point, they're defining it as marijuana only, but they're also open to maybe moms who are taking Suboxone or, and have low risk as well. They actually put an RFP for this out. I'm not going to pull it up, but it is part of the list on the right-hand side. It's called the CYF Plan of Safe Care RFP. Lots of folks have expressed interest in seeing that, and that's something that's available for you to take a look at. The third prong for Delaware is medication-assisted treatment providers. So if a hospital has a mom who's on MAT and there's not risk that they're seeing, they'll actually refer that mom back to the MAT provider who will develop and oversee the plan of safe care. And that MAT provider will then do that aggregate reporting, similar to what happens in Vermont, back up to the feds. North Carolina, I think, is another really interesting example. So North Carolina, instead of using really child welfare at all for plan of safe care oversight, they actually moved the whole plan of safe care over to Care Coordination for Children, or CC4C. So CC4C is housed within the Department of Health. They sort of operate in some ways as an MCO as well. But they were really providing a lot of this care coordination to infants who were born prenatally exposed prior to these changes with the plan of safe care. And so when the state team got together and started talking about who could oversee these plans, the CC4C folks sort of stood up and said, hey, we're working with these families anyway. It makes sense for us to house these plans. So all calls in North Carolina still go to child welfare, and child welfare is going to make a determination about whether they're going to, screen that call in or not. But regardless of if they're screening in or out, they're referring all those calls over to CC4C to then develop the plan of safe care for those families, and then they engage that family. And if a child welfare case is open, CC4C will work collaboratively with child welfare to support that family. Lots of development challenges. Again, really this is understanding your jurisdiction and your community and what works. I often hear there's a lot of time constraints in medical environments that makes it difficult for them to develop a strong plan of safe care. The other piece for me is the information gathering by hospitals. So as you heard, in a lot of states, hospitals are making a determination to call child welfare to make a report versus a notification. You heard that a little bit in Vermont as well as Delaware. That really brings up for me, what information is that hospital gathering about substance use disorder treatment? If they have a mom who says she's on medication-assisted treatment, are they getting information about that adherence to MAT before making that decision? There's a lot of nuance in there. Hospitals do, and hospital practice really varies from hospital to hospital, but it's something that we've spent quite a bit of time in with our sites. I think we also have seen the issue of redisclosure of substance use information. So, 42 CFR confidentiality regulations say that if I get information from a treatment provider, I can't turn around and give that information to someone else. That comes up a lot. So if I'm doing care management, can I get information from substance use and then maybe turn that and talk to the OBGYN about that? So I think there's lots of opportunities for redisclosure to happen. So folks need to be really careful about the role of consent in these plan of safe cares. So oversight, who develops the plan of safe care in many places is different than who actually manages it. And when we're talking about managing, it's sort of supporting the information sharing and ensuring that that mom is sort of engaging in the services of the plan of safe care overviews. I think that also looks different in different jurisdictions. So we mentioned Maryland earlier today. So child welfare really is developing the plan of safe care at birth for all families in Maryland. And they're really looking at how, again, just as we talked about with Allegheny County, how can they really start sharing that plan of safe care? This is in the early stages with Maryland, but they're talking with their treatment providers, again, to see if they would be willing to implement a prenatal plan of safe care that could get shared to child welfare and then potentially even shared back once child welfare closes if it's a pretty small short window. They're also looking at developing a state toolkit, and this toolkit is modeled off of something Kentucky did to support counties with implementation. So Maryland's a really county-driven state, and so the state really is giving guidance so that counties have to have a plan of safe care, but they have a lot of flexibility in what that looks like. And so the toolkit is going to have information about best practices. It will have a template plan of safe care that they might want to use, information about screening, and really a push to get upstream into that prenatal period of time. And so Maryland really modeled that, again, on Kentucky. Kentucky took this really nice regional approach, and at that time they had some tobacco settlement dollars that really supported this. It's really driven in Kentucky by substance use disorder treatment, who are really the holders of the plans of safe care. But they developed, again, a really nice toolkit. You guys can go ahead and pull that toolkit up now. But so they developed a toolkit, and then they sort of shopped it around regionally and did a series of trainings really across the state to talk about what it would look like. It included a really nice flow chart, so if communities really wanted to sort of get down and implement in this procedures in their community, they had this guide to do that. This continues to evolve in Kentucky. My understanding is they've developed a number of tools to help develop the sort of the core teams and the steering committees and who really needs to be involved and that kind of thing. But the toolkit's kind of at the heart of moving forward. So you can see there's a nice MOU that's included so that they can start facilitate information sharing, some best practices, and they go through the 5 points of intervention, and they include information about their plan of safe care as well. So we can go back to the slides. So, if and we hear this in many, many states that we're working with, is that child welfare really is the holder of that plan of safe care. And so I think there's some decision points to think through when child welfare is the holder. So again, one, is it a shareable document? Is it something that we can share with our partners? Oftentimes, if child welfare is overseeing the plan of safe care, it's not necessarily a tangible single document, but really it's the culmination of multiple different assessments, right? And so that makes it really difficult to say, hey, can you share that plan of safe care? And so I think that's why we encourage child welfare to think about creating a standalone document if it's possible. Again, that would then support collaboration. So these are the family's goals. Can you support us to support this family, right? And also why we're thinking about, if child welfare isn't doing a standalone plan of safe care, I think there's then some opportunity to develop that prenatal plan of safe care and share that with child welfare so that providers, substance use treatment providers have some input, right, and have a voice to say, hey, this is the work we've been doing with this client in the prenatal period. And again, I mentioned this a little bit earlier, but if that's a short assessment period of a month or 2 months within child welfare, how can we hand that plan of safe care off? Because this mom will probably still be involved with substance use disorder treatment. So how can we, capitalize on the work that child welfare does so that substance use can continue the progress and the momentum on addressing a lot of those goals? So I mentioned this a bit earlier in terms of moms on MAT. I think there's a lot of sites looking at what does adherence mean within treatment at MAT. I'm finding that lots of providers are getting consent signed prior to moms going in to give birth, and they're ready to share information. Hospitals aren't always asking and getting a complete picture of what's going on, so I think there's some work in there to do to make sure that that information sharing is getting across. So we want to get more than just dosage information. I think we want to understand adherence or compliance or challenges that mom's having. I think stigma can really impact information sharing. So if the MAT provider is worried about what that hospital is going to do or how they're going to treat their client, there might be some resistance to information sharing. So, we had the pleasure of having Dr. Grossman, who oversaw the Eat, Sleep, Console method at Yale New Haven Hospital, and he talks a lot about how he transformed his NICU to be able to engage moms and dads to come on site, and a lot of it was really about stigma busting. So we have that link to that webinar. It's something we can share. It's, I think it's a really wonderful resource. And I think the MAT providers, we're seeing lots of providers start to work with moms to create sort of a birth plan prior to going into the hospital. That would include, if a prenatal plan of safe care existed, it could include a copy of that. It can include something of kind of a progress report about how she's doing in treatment. It could include copies of signed consents or just other documents that would support that hospital and that decision about, am I calling child welfare on a notification versus I'm calling to report concerns about child abuse or neglect. Again, ideally, there's this opportunity prenatally for SUD or MET providers to work with moms and develop that prenatal plan of safe care. I think we're seeing lots of sites really considering how to use substance abuse specialists or coaches or folks with lived experience to engage women. At OBGYN offices, they're super busy there, so whatever we can do to reach out and engage those folks, I think, is a strength. We talked about this opportunity that prenatal plan can get sort of handed off back to child welfare and then come back. And again, I think the big piece is we know this infant is coming. We can really mitigate the crisis at the birth event if we start to plan ahead during that prenatal period. So I just want to show you one more resource, which is the Mission Hospital brochure. So Mission Hospital is in Asheville, North Carolina. They do a nice brochure. Really, the front half of this brochure is all about neonatal abstinence and withdrawal and treatment. And they give this to moms when moms come and do a tour of the hospital, and they learn about rooming in and all of that wonderful stuff. And at the back end is a really nice plan for that mom and her infant. And so it talks a little bit about neonatal abstinence. It talks about the expected length of stay, because we often hear that moms are surprised that those infants are going to get held. It talks about what's happening with DSS and then transportation to get their MAT while they're in the hospital. So it does a nice job of pulling all these pieces together. The other resource that I reference on that slide is the Massachusetts Journey program. So this is a nice website, and it's really geared towards moms to help prepare them for the birth event. But one of the things that the Journey website includes is another kind of version of this, but a nice sort of birthing package, like a checklist of all the things that that mom can think about bringing with her. A lot of those things I mentioned earlier, like the progress reports and signed consents and plans of safe care and all that. We can go back to the slides. So I know we moved through this pretty quickly. I'm going to pass this back to Ken for to do some discussion and answer some questions.
Sure. Thanks, Jill. Thanks. So, as a reminder, you have the chat box. You can enter questions. Let me start with the question that Karen posed, and we'll come back to these discussion questions and give you an opportunity to pose some additional questions. So, Jill, Karen asked, prior to their involvement in the plan of safe care, what kind of services did CC4C provide, North Carolina CC4C, in the health department?
Yeah, so they provided care coordination for infants. It was sort of a 0 to 3 care coordination for infants who had some kind of a health issue going on. And so basically, if an infant had been in the NICU, hospitals generally were referring to CC4C prior to the plan of safe care role that they took on. And so they provide care coordination. They will do some home visits as well. They do some developmental screenings. They have a pretty close relationship with early intervention services as well, so they go back and forth. So it's been interesting that the infant is their primary client, but because parental substance abuse impacts that infant, they're also able to work with that mom or primary caregiver if that, that caregiver needs to access treatment or that kind of thing.
Thanks, Jill. I'm not sure, but they may be the Healthy Start provider in North Carolina, but I'm not 100% sure of that. We can find that out. So some of the discussion questions, and you indicated on the earlier polling question the role of the court. About 48% of you said yes, the court's involved, and about 25% said no. So we kind of want to open this up. You can unmute your phones by pressing *2, but what is the role of your court team in serving this population, implementing plans of safe care? I think we're working with you, and I think Jill presented today numerous examples of the kinds of local implementation strategies that I think all sites can consider within the framework of your state regulation, state guidance around implementing plans of safe care. And that's really our focus, is your local implementation, and what are those local implementation strategies to address this population, these families, and implement plans of safe care within the framework of your state. I almost want to say regardless of the framework in your state. But what I mean by that is that there are certainly a lot of what you heard today, and what we'll talk about with you as we come back on site, as we continue our work in the next year, is to look at those strategies, including the role of the court in implementing plans of safe care and addressing the population of infants and children and families affected by substance use disorders and prenatal substance exposure. Would anyone like to discuss the role of your court in serving, and your team in serving this population? Okay, let me go through these questions, and these reflect the conversation that Jill had today, and it reflects the conversation that I'm asking the change leaders and the change liaisons and the evaluation liaisons to have with your teams as we move forward, to really understand what enhancements, what services you're providing to address the needs of this population. All of you have existing courts, and there's a diversity of the types of those courts. We have family wellness courts and family drug courts, several tribal courts, a number of early childhood, infant toddler courts, if you will. And we want to help you identify those strategies, those activities that address the needs of this population and looking at meeting the need. What's your court team doing or planning to do, planning on doing differently to better serve this population? I know that a number of you are working with your evaluation liaisons and the change liaisons around counting. How do we count a quick participant in our court? What distinguishes a quick participant within our existing courts from the other participants in our specialty courts? And we want to help you identify that population, but it really comes before that in understanding what services you're doing to address the needs of this population. And I think back to the original two goals around capacity and implementation, and some of the processes that would reflect some different practices to address the needs of this population. Certainly we've talked about linkages between maternal and infant health care providers and hospitals, the court, child welfare, and substance use disorder treatment providers. We've talked about developing prenatal plans of safe care. And again, almost every jurisdiction, unless there's already an open child welfare case, plans of safe care are not developed until birth, and that in child welfare is not involved during pregnancy. But there are women that come into substance use disorder treatment that may not be getting prenatal care. How do those treatment agencies prepare a woman for birth, and can those agencies develop plans of safe care during prenatal care so that plan of safe care is in place at the time of birth? And again, that can be regardless of whether child welfare is incorporating plans of safe care into their work, whether it's a freestanding or standalone plan of safe care. But it, as Jill said, it mitigates the crisis response, and what a difference it would mean for a child protective services worker to go in and into a hospital with birth and be aware of and be told, here's a plan of safe care. We know that the mom's already involved in substance use disorder treatment, has been having prenatal care, has a prenatal provider. We've identified a pediatrician for post-hospital discharge services. A certain agency might be doing home visiting to support that family at discharge. Just think of the difference that would make in CPS work in developing a plan of safe care at the time of birth. Enhanced training and resources for collaborative partners on infants and children, and understanding this work and everything that goes with it.
Yes. We have one comment from Jennifer Walters, and I think this is a good point. It's in response to the first set of questions, and she said that the court judges are conveners and they play the role of conveners. I don't know if you wanted to respond to that, or Jennifer, if you wanted to say anything more about that. To unmute, you have to press *2 to speak.
Absolutely, the judges are conveners and really critical in convening the partners in your court teams to carry out this work. And we know that most specialty courts revolve around and are created around the vision and the leadership of specific judges, of particular judges in this jurisdiction. And it becomes increasingly important for those judges to be, I think, talking about advocating for plans of safe care, to be knowledgeable around plans of safe care and the implementation strategies around the CARE amendments to CAPTA, and provide that kind of leadership, certainly within the court team, but beyond the court team in terms of in the community. The judges have a tremendous standing in the community, and folks listen to their leadership and their role in educating the community about this approach to families. Is vitally important and something that can be incorporated into all of your courts. Thanks for that, Jenny. our child welfare colleagues are well aware of the priority that's come from the Acting Associate Commissioner for the Administration of Children, Youth, and Families, overseeing the Children's Bureau, the prevention strategies that Commissioner Milner has put out, and he really describes primary prevention, community-based prevention to prevent child abuse and neglect, to prevent families from even coming into contact with the child welfare system, in addition to preventing at-home care, which is often considered more traditional prevention services, if you will, as well as alternative response systems. And I think your courts and your teams have an opportunity to get upstream, if you will, and to devise prevention strategies for this population. We've been on site, we've spoken with you as you've expanded your collaborations to prenatal care providers, to hospitals, to post-hospital maternal and infant health care providers. And if you're doing that for notifications for families that are coming into the attention of child welfare, those collaborations and linkages then are already occurring. And why not apply those collaborations, those linkages, those communication protocols, that information sharing? Why not apply that to pregnancy, to prenatal care? You've heard me say on site in several jurisdictions that whether they're county commissioners, whether they're state legislators, your governor's office, are all very focused on not just responding to the needs of infants and families that are affected by prenatal exposure in terms of what happens at birth, but they're very much focused on what can we collectively do to mitigate, to prevent prenatal exposure, to prevent those births in the first place. And one of the ways, the tangible ways that the court teams can do that is by applying your strategies, your creativity, your collaborative work, and applying that to prenatal care and to pregnant women through your healthcare practitioners, through your SUD treatment providers, and through other community agencies such as public health that are also supporting women during pregnancy. So, like I said, we'll be following up with you in the coming months to help you articulate and really define the strategies. Many of you have already done that and have implemented additional parent-child interventions, parent supports, education around this population for infants and families, and we want to help you really flush that out in the coming months, as well as help you articulate and identify how you can count those participants, and then work with you to develop sustainability strategies by which the innovations and enhancements that you're implementing can be sustained. Can we go to the close out the remaining slides here? So here's the Plan of Safe Care guidance document. It's on it's available through us. It's not on the website, but it's available through your change liaisons, and it's available by emailing us at nationalcenter@cffutures.org, and we provided most of those resources to you. We provide the guide to you already, but probably many of you may not have it, so feel free to ask that of your CLs. And then the landing page, this webinar landing page, and all the resources, the resource guide that we've indicated here in the webinar are also available on this on our quick web page, if you will, for CF Futures. So if folks who aren't on the webinar today, if you want to provide them this link where they can access all the resources as well. And then the next slide indicate.
Okay, we did post the planning guide, so that's available for download online, and it's also available in the Files pod. Right. And then we'll be posting the webinar recording on the same landing page. Great,
thanks, Ashay. And then upcoming webinars and next steps. So we're working with Mimi Laver and at the American Bar Association Center for Children and the Law, and one of our subject matter experts, Hillary Cushion's, on an attorneys forum for attorneys that are currently involved with your court, with your teams, coming up January. I say the date's coming out probably later this week on that, or early next week. Work with Dr. Chasnoff on a follow-up webinar from the All Sites meeting. And most of the CLs and evaluation liaisons are working with you to schedule year 2 site visits. And then in July we're having again the year 2 all sites meeting. We encourage you to talk to your CLs about any ideas that you have for making that, helping us meet your needs with that meeting as well. And you know how to get hold of us. So we thank you for your time today. We wish you well and wish you blessings for a blessed holiday season and a safe holiday season. We look forward to seeing you in July, and we look forward to seeing you before that on site visits and our continued work with you. Jill, we appreciate your presentation today, and take care, everybody. Thank you.